Hello and welcome. I am Tanya Chamberlain from the Division of Anatomy here at the University of Leeds, and in this video we will be taking a peek of life in the beginning as we delve into the world of embryology. Let's have a look at the learning objectives for this video. After this video and any necessary further study, you should be able to use appropriate terminology to describe the embryo. Describe the techniques used to date a pregnancy. Describe some of the congenital malformations and discuss their causes. Describe the structure of male and female gametes. Outline how hormone levels fluctuate during the menstrual cycle and how they change if fertilization occurs. Outline the process of fertilization from the capacitation of sperm to blastocyst formation. Describe the development of the embryo, of the zygote to the pre-implantation blastocyst. So what is embryology? Well, embryology is the study of the developing embryo. Despite where our paths may take us, we all started our lives as a sperm and an ova coming together and producing a diploid mass of cells that inhabited a uterus for a while before making our mark on the world. Certain fields in medicine will have specific interest in embryology. These can include obstetricians, geneticists, and paediatricians. Now, I appreciate that many of you will not go down these specialties. Many of you will never even do rotations in these specialties. So why am I teaching you this? Well, to get to the point, embryology provides us with a blueprint for anatomy. We can also refer to this blueprint of anatomy as developmental anatomy. Take this example here. The organ on the right is the pancreas, but it doesn't look like this as it develops. Instead, it looks like the pictures on the left. It forms from buds in utero, and as the gut develops, it rotates and these primitive pancreas come together and fuse. Embryology explains how we transform from two sex cells into a whole human being with 30 trillion cells. Not only does embryology provide developmental anatomy, it also provides us with the ability to predict the pathway of disease, so it helps us predict the course of pathologies. So this image represents a biological male pelvis with a single testis. The testes develop in the abdomen and begin to descend about week 10 in utero, finally completing their journey at about week 25. As they descend, they take a collection of lymphatics and vessels with them from the back wall of the abdomen. When we consider diseases like testicular cancer, we are able to predict the course of that cancer because of the journey of those early testes. So when diagnosed with testicular cancer, clinicians will often look for disease spread to the retroperitoneal lymph nodes, which are located on the back wall of the abdomen. Embryology can also help us understand biological variation. Take both of these images as example. The image on the left demonstrates a horseshoe kidney. Hopefully we all know that kidneys are expected to come in pairs, but this is one biological variation that isn't that uncommon. In fact, it is estimated that about 1 in 500 people have this condition. Thankfully, this condition is usually completely benign, meaning that it causes no issues, and it is usually found incidentally when searching for another issue. The image on the right, well, that isn't quite the same. When we look at this image, what we can see is the heart is flipped around the wrong way. So instead of pointing off to the left, the ventricles are pointing to the right. This is called dextrocardia, which falls under the umbrella term of a situs inversus. So why can dextrocardia be a problem? Well, in dextrocardia, the heart is the only viscera, which is a name we call a collection of soft tissues inside the body that aren't skeletal muscle, to be flipped around. This means that the veins and the arteries are plumbed into the heart incorrectly. When you think about the hearts, the ventricles are designed slightly differently. The right ventricle has a thinner muscle wall to keep blood pressure to the lungs lower, but the left ventricle is designed to have a thick wall suitable for pumping blood around the whole of the body. Therefore, with dextrocardia, what we end up seeing is that blood pressure inside the lungs is high and blood pressure to the body is low. Not only does this mean that we damage the lungs, but it also means that the body and the brain are poorly perfused. And now we finally have our last reason to study embryology. This is because it helps us to understand the development of congenital malformations. On this image on the right, we can see that the probe is inserted into a space. This space shouldn't be here. The diagram on the left shows an overview of the heart. When looking at fetal circulation, we have circulatory shunts in place because we don't use our lungs to fulfill our oxygen requirements. Instead, the fetus relies on the placenta. When we take our first few breaths out of the uterus, the change in the thoracic pressure shuts these shunts so that we can redirect the blood flow to the lungs. This shunt is called the foramen ovale. After a few breaths, it snaps shut and is called the fossa ovalis. Sometimes this foramen or hole fails to close, and we have what we call a patent foramen ovale. This is a congenital heart defect and can commonly be referred to as a hole in the heart. It is not the only type of hole. There are also atrial septal defects, or in some cases ventricular septal defects. But the embryology of the developing heart offers explanation as to why these congenital abnormalities occur. So now we have looked at the embryology, let's start uncovering some of the terminology we need to grasp before we can uncover what is happening at the earliest stages of our lives. Firstly, let's address some direction issues. The first picture shows an adult human stood facing off to the left for comparison. The adult human is a stretched out version of an embryo, so we use slightly different terminology for anatomical position. In the adult human, you may have heard the terms inferior or superior. In the embryo, we refer to this as caudal or cranial. This is because the embryo is C-shaped or prawn-like. The cranial direction is in relation to the head or the cranium, whilst the caudal direction is in relation to the caudal region, which is another word for tail. So if I say that the arms of the embryo are cranial to the legs, what I'm saying is that the arms grow closer to the head than the legs do. The three pictures on the bottom refer to different planes in which we can view the embryo. The leftmost image shows a cut from one side of the abdomen to the other side of the abdomen. So we have divided the embryo into cranial and caudal parts. The middle image shows an embryo with a line extending from the head through the umbilicus or the belly button, and we have divided that embryo into left and right. If this line travels directly through the middle of the body, we call this a mid-sagittal plane. If we have just taken off a shave, this line doesn't fall directly through the midline, we call it a sagittal plane. And lastly, the final image shows what happens if we cut the front of the embryo from the back of the body. This is called a coronal plane and divides the embryo from front to back. When it comes to dating a pregnancy, there are a couple of ways in which we can do this. As general practicing clinicians, the way you will often date a pregnancy will be to ask the expectant patient when the first day of their last period was. This is the first day of their menses or period. This is a useful way of identifying the rough gestational age of the fetus, which is necessary for most day-to-day monitoring of the pregnancy. This method is referred to as calculating the menstrual age of pregnancy. Then we take the the pregnancy to be approximately divided into 3 trimesters, where trimester 1 stretches from the first date of the last period to week 12, trimester 2 begins at the beginning of week 12 and 1 day to week 28, and trimester 3 at the beginning of week 28 and 1 day to week 40, which is the estimated due date of the fetus. The menstrual age is useful because it is non-invasive, it is quick, and most patients will have a rough idea of when their last period took place. However, it is not always accurate. Patients do not always know the date of their last period, and in particular patients with conditions such as polycystic ovarian syndrome or those on some contraceptives may not have regular periods, so dating a pregnancy in this way can be difficult. However, embryologists and those clinicians with a particular interest in obstetrics will need to know with greater accuracy the date of the embryo. Embryologists use something called the fertilization age. This is the day at which fertilization took place. For reasons we will come on to towards the end of this video, this is not the same day at which sperm was deposited, but the day that sperm penetrated and fused to the nuclei within the oocyte. The fertilization age is also divided into 3. We have the early development period from weeks 0 to 3, the embryonic period, or sometimes called the organogenesis period, from weeks 3 to 8, in which all of the organ systems begin their development, and we have the fetal period, which is from weeks 8 until delivery. You'll notice that the fertilization age relies on a 38-week gestation time frame, whereas the menstrual age is 40. This is because the period used to date the menstrual age of the embryo happens before fertilization takes place. This is based on textbook patients' periods lasting 28 days, in which ovulation occurs on day 14. But we know that this is not always the case, which is one of the reasons why menstrual age is not always that accurate. Additionally, whilst trimesters are handy for generic medical practice, they tell us very little about the embryo itself. You can see from the purple side of this timescale that most of the development of the embryo happens by week 8. The rest of the gestation is largely just growing and developing the organ systems. Embryologists study how the embryo develops, largely within the first 8 weeks of development. So having an accurate date is particularly important when we are looking at the blueprint of that future individual. And why is that important? Well, it is important because it helps us to understand the causes of congenital defects. 1 in 44 births in the UK are affected by a birth defect. The majority of these are detected antenatally or prenatally, which just means before birth. But we can see that sometimes a birth defect isn't noticed instantly, sometimes taking a month to notice. In fact, some of the congenital defects aren't diagnosed until adulthood, particularly when we look at some of the congenital defects of the heart. The patient's body has been fairly efficient at hiding these defects throughout the first 30 or 40 years, but then overcompensating systems begin to fail. There are a number of causes for congenital defects. The one you'll most probably be aware of is chromosomal abnormalities, such as Down syndrome. But chromosomal abnormalities only account for about 10% of the entire population with a congenital abnormality. We also have other genetic factors, such as those with a single gene disruption, as in the case of cystic fibrosis or sickle cell anemia. 7% are caused by environmental factors. This could be exposure to radiation or maternal ingestion of a drug, or even paternal exposure affecting the sperm. However, what we have established, as it is most frequently, it's not a single event occurring, but a genetic, chromosomal, or environmental factors coming together. This is why 25% are considered multifactorial, a combination of genetics and environmental factors. And even though we are constantly studying the causes of congenital abnormalities, it remains that about 50% of the causes of congenital abnormalities are unknown. Given the high incidences of congenital abnormalities at 1 in 44, this just goes to demonstrate how difficult it is to pinpoint an exact cause of something which will likely go on to affect the patient for the whole of their life. So now we've looked at some slightly concerning stats, let's have a closer look at a few of those. So we have uncovered genetic causes of congenital abnormalities, but what do these look like? Well, these can have a monogenic inheritance. This is where either the paternal or maternal DNA, or sometimes both, carries a single gene mutation, as in cystic fibrosis. Chromosomal causes of congenital malformations can arise in a few ways, but can be summed up in two. We can either have a numerical issue or a structural issue. A numerical issue, or aneuploidy, is one you are most likely to be familiar with, and this can be seen in individuals with Patau syndrome, Edwards syndrome, or Down syndrome. And these are all considered trisomies. But there are other aneuploidies that are caused by a reduced number of chromosomes, such as Turner syndrome. Down syndrome is also known as trisomy 21, and if you look at the karyotype on the right, you will see that we have 3 copies of chromosome 21. In trisomy 21, we often see individuals with growth retardation, meaning that they are shorter than the average population, intellectual impediments, and craniofacial dysfunctions and congenital heart defects. Now we can see a huge variation in the presentations of these chromosomal abnormalities, with some individuals being significantly more impacted than others. And the reasons for this are far beyond the scope, but if you are interested, have a quick Google at something called mosaicism. Structural chromosomal defects arise when there is a chunk of DNA on the chromosome which has undergone a change. This could either be a deletion, a duplication, an inversion, where it is flipped upside down, or a translocation, where it is detached and stuck to another chromosome. Examples of this are beyond the scope, but are called Cri-du-Chat or Pallister-Killian syndrome. We also mentioned that congenital birth defects can be caused by the environment. If the environment is a factor, we call this a teratogen. In a nutshell, any environmental factor that impacts the developing embryo or fetus causing the development of a congenital abnormality is a teratogen. This could be something infectious invading the maternal circulatory system, a chemical ingested, either pharmaceutical or illicit drugs or even alcohol. We all know the risks of radiation in pregnancy, but have you considered that maternal disease may also play a part, such as maternal obesity or diabetes? And lastly, a deficiency can also be teratogenic. In this example, we have folic acid, but there are many other nutritional deficiencies that cause a congenital defect. Now, not all known teratogens can cause a congenital defect all the time. We have to consider how much of the teratogen the embryo or fetus was exposed to, and when that embryo or fetus was exposed. On this graph, we can see that there are certain points in the developing embryo. There is quite a narrow window in which they are particularly susceptible to the developmental disruption that leads to a birth defect, and this is largely around weeks 3 to 8. We have seen from previous images that this is the embryonic period, or the organogenesis period. This is when all the organ systems are beginning to develop. You'll notice that the risk never drops to 0. That's because even at full term, whilst the fetus is inside the uterus, they are still at risk of teratogenic exposure. But the impact of that teratogen drops significantly as the fetus ages. So let's have a closer look at the sensitivity of the fetus or embryo towards teratogens. On this slide, we can see a selection of some of the key milestones of development. For the early embryonic period, the weeks 0 to 3, we can see that the pre-embryonic stage aren't susceptible to teratogens. This isn't strictly true. Whilst before implantation the sensitivity to teratogens is incredibly low, there is no exchange of maternal or embryo nutrients, or therefore teratogens. But once that pre-embryonic blastocyst implants at week 2, there is considerable risk to teratogenic exposure. But there is very little risk of developing a congenital defect as a result. And this is because most pregnancies will result in a very early miscarriage, and therefore there is no congenital abnormality developed because the pregnancy that is so affected that it's not viable. The bars on the graph demonstrate two regions. We have a darker red region and the paler orange regions. These represent the degree in which an organ system is susceptible to major and minor congenital abnormalities. We can see for the most of these systems the critical time points of development are between weeks 3 and 8, and so disruptions to their development during this time period will have the greatest impact and create the most severe congenital malformations, whilst disruptions after this window will likely result in minor malformations. The most obvious exception to this is the central nervous system, which continues to have significant developmental steps through to week 16. So let's have a closer look at a few teratogens and the impact on individuals that were exposed to them. Firstly, we have infectious teratogens like toxoplasmosis, hepatitis, rubella, cytomegalovirus, and the herpes simplex virus. What all of these have in common, like with most teratogens, is that they cross the placenta. Toxoplasmosis is a parasite found in undercooked or raw meat. It is also found in cat feces, which is why pregnant people are advised against cleaning cat litter trays. Unfortunately, as with a lot of teratogens, the pregnant person is often asymptomatic, and so this infectious disease is missed. However, the same cannot be said for the offspring. We see congenital malformations in the eye, such as retinal inflammation or small eyes referred to as microphthalmia. We see babies born with significant hearing loss and an enlarged spleen. We also see central nervous system malformations such as hydrocephaly or microcephaly. The image on the left shows hydrocephaly. Notice this infant's large head, which has been caused by excess cerebrospinal fluid buildup and has pushed the flexible bones of the skull outwards to accommodate for the ever-increasing intracranial pressure. The next infectious teratogen is rubella. Rubella is also known as German measles, acquiring its popularized name from the first mention in early German literature by German physicians. This is passed through the placenta in the very first 3 months of pregnancy and causes eye, central nervous system, and heart defects. We had seen a reduction in the cases of rubella congenital malformations, but there have been the odd peak here and there in the last 20 years, which may have arisen due to the 90s decrease in the MMR vaccine uptake through fear of its association with autism. This is now a debunked theory. Cytomegalovirus is one of the herpes family of viruses, and it is fairly common in the population. It is usually asymptomatic or disguised as a mild viral infection, like a mild case of the flu. Again, with this infectious teratogen, we see eye defects like retinal inflammation and microphthalmia, enlarged liver and spleens, and the central nervous system defects. This image on the right shows the CT scan of the mineral deposits in the brain that we often see in infants born having contracted the cytomegalovirus in utero. The herpes virus. So we have seen a lot of herpes viruses that are teratogens, but one to note is the varicella zoster virus or chickenpox. Fairly mild if contracted outside the uterus, but can be extremely dangerous in uterus or in brand new babies. It is significantly disruptive to the development of the limbs and the central nervous system, but we have also seen segmental skin loss and scarring. Thankfully, most pregnant people have already contracted the virus before reaching puberty, but exposure to chickenpox should be avoided whilst pregnant, particularly between the weeks of 13 and 20 and during the last few weeks of pregnancy. One of the newer emerging viruses is the Zika virus. This mosquito-borne virus, found in tropical and subtropical regions, can not only be spread by mosquitoes but also by an infected person through sexual transmission. So the WHO recommends practicing safe sex or abstinence for a period of 3 months for men and 2 months for women who are returning from areas of active Zika. This prevents sexual transmission to their partners. So Zika has been shown to significantly affect the developing nervous system of fetuses, in particular with microcephaly and severe cognitive disability. Teratogens are not only infectious diseases but can be chemical too, as in the well-known case of thalidomide. Originally developed in West Germany as an antidote to morning sickness, thalidomide was used throughout pregnancy and saw significant limb defects in resulting fetuses. It is now used to treat leprosy and HIV, but precautions must be adhered to in prescribing the drug in pregnant patients. It is now advised that females of a childbearing age are limited to 4-week cycles of the prescription and are pregnancy tested on the day of dispensing. They are also counselled with effective use of contraception and the importance of not engaging in unprotected sexual activity whilst taking the prescription. Another chemical teratogen is alcohol. In-depth research into the teratogenic effects of alcohol have been conducted over the years, and it has been determined that there is a clear relationship between the volume of alcohol consumed versus the directly related to the severity of the defects produced. We see individuals affected by fetal alcohol syndrome sharing stereotypical craniofacial features, such as small eye openings, a smooth philtrum and a thin upper lip. We can also see they are often smaller and shorter than the average population and experience intellectual disabilities along with motor and coordination impairments. We have also seen the effects of physical teratogens such as radiation. Any females of childbearing age that have been for an X-ray or CT will know they are routinely asked for the date of their last period. This is to ensure that the patient is unlikely to be pregnant at the time of exposure. Most of what we know about the exposure of a fetus to radiation has been from radiation disasters such as the Chernobyl power plant disaster, or from how we know radiation acts on DNA. As yet, there are no documented evidence of iatrogenic radiation exposure, that is, radiation as a result of diagnostic imaging, causing birth defects. But the risks are well documented, and as clinicians, your role will be to weigh up the risks and the benefits of exposing a pregnant patient to ionizing radiation. In infants exposed to large amounts of radiation, we have seen central nervous system defects such as microcephaly and mental and cognitive disability. We have also seen hemopoietic malignancies, so cancer of the blood cells, and leukemia. Maternal disease could also have a teratogenic effect on the developing fetus. Maternal diabetes is an example of this. This could be arising from a patient with pre-existing diabetes or a patient that develops gestational diabetes whilst pregnant. There are an array of cellular defects and changes in physiology of the babies born from uncontrolled maternal diabetes. We see some of them with macrosomia, as seen in the picture. You can see that these are from similar age babies, but one is much larger than the other. This is macrosomia. We also see some congenital heart defects such as ventricular septal defects, spina bifida, and kidney disorders such as renal agenesis. Folic acid has long been established in the development of the nervous system. A diet deficient in folic acid have been linked with neural tube defects such as spina bifida and anencephaly. Thankfully, research in the USA has shown that fortifying the diets of the population, the incidence of neural tube defects has decreased by approximately 60%. Products such as wheat and cereal-based items are routinely fortified with folic acid, and this is now taking hold in the UK, as it is soon to be implemented in wheat and cereal-based food products. In addition to this, individuals planning pregnancy are advised to take over-the-counter supplements prior to conception and over the course of the pregnancy, particularly in the first 2 trimesters, to prevent the development of neural tube defects. Okay, so that was a lot of information about the background of embryology and teratogens that can affect the developing fetus. Now let's have a look at the actual development of the embryo, beginning with gametogenesis, or the development of the gametes, or the sex cells. So gametes are haploid, that means they contain half the number of chromosomes than that of somatic cells of the rest of the body. They are produced from stem cells within the sex organs, and when fertilization occurs, one of the sperm and one of the oocyte restore the number of chromosomes and produce a diploid zygote. We are going to take a slight detour and have a look at the development of female gametes, the oocyte, before we can go into the process of fertilization. So hormones play a significant role in the development of the maturation of oocytes. The hormones are first secreted by the hypothalamus in the brain, which pass on to the pituitary gland, also in the brain, which then encourage the secretion of further hormones that enter the bloodstream and act on the gonads, in this case the ovaries, but a similar pathway is involved in the production of sperm, except the gonad in question is the testes. Now, because this pathway begins in the hypothalamus and continues in the pituitary and eventually reaches the gonads, this is referred to as the HPG axis. The HPG axis is regulated by careful positive and negative feedback loops throughout the menstrual cycle to develop the secondary oocytes ready for ovulation and fertilization. So on this image we can see the hypothalamus and the pituitary gland over to the left. Remember, this is in the brain. There are 2 types of neuron or brain cells in the hypothalamus that secrete a hormone called gonadotropin releasing hormone. This GnRH then travels to the anterior pituitary gland and acts on a couple of different neurons there. These neurons in the pituitary gland are going to start secreting a classification of hormones called gonadotropins. Specifically, they are going to secrete FSH and LH, or follicle stimulating hormone and luteinizing hormone. These gonadotropins, FSH and LH, then enter the bloodstream and make their journey to the target organ, the ovary. Once in the ovary, they are going to start acting to develop the female gametes into something that can be fertilized, called a secondary oocyte. However, we need to take a little zoom in before we look at this. Now, whilst we are still in utero, biological females' primitive ovaries contain stem cells called oogonia. These are diploid cells that contain all 46 chromosomes. In the first few weeks of embryonic development, these stem cells, oogonia, begin to proliferate and differentiate into primordial follicles, again with all 46 chromosomes as represented by 2N. This differentiation is then arrested until the child begins puberty. Once puberty begins, these primary follicles need to be matured before they can be fertilized, and this happens every menstrual cycle, which is where we will begin the journey. At each menstrual cycle, localized androgens act on the primordial follicle and encourage it to mature into a primary follicle. Once the primary follicle has developed, FSH from the pituitary and a touch of LH from the pituitary act on the primary follicle. These act on the primary follicle's thecal and cuboidal epithelial cells to convert cholesterol and more localized androgens into estrogen, as the primary follicle develops into an early secondary follicle. More of the same happens now. The early secondary follicle receives FSH and a little LH from the anterior pituitary and in turn secretes more estrogen until it becomes a late secondary follicle. On this late secondary follicle, we could see that we have developed these little pockets of fluid in the cuboidal epithelial layer. This is called follicular fluid. As the late secondary follicle receives more FSH and a little of LH, it in turn kicks out some estrogen as it differentiates into a Graafian follicle. We can see that the follicular fluid has coalesced into a large well of fluid called an antrum. The late secondary follicle has undergone meiosis, and we now have a secondary oocyte with half of the genetic material enclosed in a Graafian follicle, with a large pool of follicular fluid called an antrum. This whole phase is known as the follicular phase of the menstrual cycle. But let's have a look at what happens to the hormones of the HPG axis. As we increase the secretion of estrogen, this is fed back to the hypothalamus and the pituitary, and there is less secretion of FSH and LH as we reach the mid-follicular phase. So this negative feedback loop from the estrogen causes less secretion of the gonadotropins. And this is how it looks graphically. If you look between days 6 and 9, we get a slight drop in FSH, LH and estrogen. But what about this? A sudden rise in estrogen. Once estrogen has reached a threshold level, it starts to act a little differently. Alongside the Graafian follicle, instead of exerting a negative effect on the hypothalamus and the pituitary, it starts to exert a positive influence on the HPG axis. At the same time as the threshold is reached, the Graafian follicle releases a protein called inhibin B, which acts on the neurons producing FSH and stops the secretion of this gonadotropin. And LH is secreted in huge amounts instead. This is called an LH surge. Let's take a closer look at the Graafian follicle. We can see this dark blue membrane wrapped around a bunch of granulosa cells. These granulosa cells are what will become a corona radiata of the secondary oocyte. But how do we get to that secondary oocyte out of the Graafian follicle? Well, the LH secreted during the LH surge acts on nearby vessels to become a bit leaky. Because they become a bit leaky, they leak fluid into the antrum of the Graafian follicle and cause it to swell. In addition to this, the LH also activates proteases which snip off that membrane enveloping the secondary oocyte. This, combined with the ever-increasing pressure, pops the secondary oocyte out of the Graafian follicle, much like bursting a spot or a blister. The secondary oocyte erupts from the Graafian follicle in an act of ovulation. So let's catch up on the graph of hormones. At ovulation, there is a huge increase into estrogen, which begins exerting a positive feedback on the LH that is secreted. The estrogen then begins to fall as ovulation occurs, and what you can see is a huge surge of LH that drops dramatically immediately after ovulation. But what about progesterone? We can see that this is beginning to climb. While the luteinizing hormone also acts on the remainder of that Graafian follicle and transforms it into a corpus luteum. And what does the corpus luteum do? while it produces progesterone. We can also see that the corpus luteum produces a little estrogen too. In a menstrual cycle without fertilisation, the corpus luteum degrades after about 10 days, and we see a return to baseline for progesterone and estrogen prior to the next menstrual cycle starting. However, if the secondary oocyte is fertilised, cells called syncytia trophoblasts secrete a hormone called HCG, which tells the corpus luteum to continue producing progesterone and estrogen until a placenta can take over a little later in the pregnancy. So that was an awful lot of information to take in, but there is a little bit more now. However, thankfully, it's a bit more simple. So in order for fertilisation to occur, 5 steps need to take place. We need to have fusion of the male and gametes. We need to have capacitation of sperm, acrosome reaction, the formation of a zygote, and the fusion of the pronuclei. Fertilisation usually takes place in the ampulla of the uterine tube, fairly close to the end of the ovary. Once sperm is deposited in the cervix, it makes its journey to the isthmus of the uterine tube and buries its head into the lining to undergo a process of capacitation, in which the enzymes of the acrosome on the head of the sperm are activated. The fimbriae of the uterine tube sweep the secondary oocyte into the uterine tube just after ovulation, and the cilia of the tube beat the oocyte towards the uterine cavity. Chemoattractants of the oocyte wake up the sperm, and the sperm travel to meet the oocyte. Once at the periphery of the oocyte, the capacitated sperm swim through the corona radiata, where they meet a crusty shell called the zona pellucida. The acrosome releases its enzymes to penetrate the zona pellucida, and once the barrier is broken, the pronuclei inside of the oocyte and the nuclei of the sperm are able to fuse, and a cortical reaction is generated within the corona radiata to prevent the penetration of any more sperm. The pronuclei fuse, and a diploid zygote containing 23 maternal chromosomes and 23 paternal chromosomes is created. Over the following few days, every 24 hours sees the doubling of cells in the zygote, from 1 to 2, 2 to 4, 4 to 8, and 8 to 16. This is a process called cleavage. Once that zygote reaches the 16 to 32 cell stage, around day 4, we change its name from zygote to a morula. This is because it looks a little bit like a mulberry, or a blackberry if you prefer. The morula begins to organise itself. The cells squashed in the middle are the embryoblasts, and because of their location are called the inner cell mass, whilst the cells surrounding the perimeter of the morula are called the trophoblasts, or the outer cell mass. The inner cell mass will go on to form the embryo, whilst the outer cell mass will go on and form the supportive structures like the placenta. Around day 5, a fluid-filled cavity forms within the morula. The inner cell mass is pushed to one end of the cavity. This cavity is called a blastocytic cavity, and once this is formed, our morula is not termed a morula anymore, it is now called a blastocyst. All the time this is happening, that blastocyst is travelling further into the uterine cavity and hopefully manages to implant itself on the anterior or the posterior wall of the endometrial lining, beginning the next step in the process of implantation. I will now leave you with this little time lapse of the steps that we have encountered today.